Welcome to Health Talk. Today we have with us Dr. Salli Tazuke. She is an infertility specialist, part of CCRM, which is a comprehensive fertility center in the Bay Area. And Dr. Salli Tazuke is going to inform us about all the new things about IVF, in vitro fertilization, and what's new and possible that we didn't know in 1978 when it first began, when the field first began. So what's new?
Thank you so much for inviting me. So yes, the first baby was born in 1978, and since then the technology improved greatly to figure out how to fertilize an egg successfully outside a woman's body, and then how to grow embryos in a petri dish successfully up to 6 days, which is what normally an embryo does in a woman's body, floating down the fallopian tube.
6 days, it's alive in the petri dish?
It's alive in the petri dish for 6 days, and it has to divide and divide and divide. And under the petri dish, we can watch and see what makes it to that end point.
And then it's reimplanted.
Mm-hmm.
And then in that 6 days when you're watching in the petri dish, is that when they do the genetic testing?
So the genetic testing is done at the very last stage, because then the embryo actually has 100 to 150 cells. So you also have cells that will be baby's placenta versus baby's body. So we can safely do genetic testing on the placenta cells and not affect the baby's body, and know whether an embryo has normal genetics or abnormal genetics.
Oh, that's fascinating. And then now that a person usually comes to your center after a year of trying and not being able to conceive, do people come to your center sooner?
They can, because some women are now realizing that they can cryopreserve eggs, cryopreserve embryos, so that if they were still busy with school or career, or not in a position to have a family quite yet, but not worry about the aging effects and lowering fertility, because that's very prominent. There's nothing we can do in terms of medical treatment against aging of the eggs. And so to be able to offer that is very powerful for women.
So that's within the last 5 years?
For freezing eggs, yes.
And so the other new thing about IVF is that more insurance companies pay for it.
Correct.
And more employers pay for this option for their employees.
Correct.
And then some medical spending accounts pay
all
for
of that, yes.
So that's been new within the last decade.
Mm-hmm.
And how about a woman wanting to preserve her fertility? Is that covered?
Yes, it is.
So that's very fascinating too.
Mm-hmm.
That's good.
Mm-hmm.
And the cost of preserving one's eggs if one wants to postpone pregnancy, so that's like a monthly fee. No?
No, it's the storage.
The storage.
Storage is an annual fee. Mm-hmm.
And then how long have they stored people's eggs?
Actually, for a long time. People have been trying to freeze eggs for decades, but they were not very successful and was considered experimental until about 5 years ago, when the freezing technology improved.
So then are all states, all 50 states have this capability? They have centers like this?
Yes.
And all major hospitals?
It's usually a standalone fertility center. So they're usually not in a hospital, because you don't need a hospital. It's an outpatient treatment. You come to clinics to monitor how your ovaries are growing the eggs in a follicle. It's called a follicle, with an ultrasound. We do blood tests to measure female hormone levels of estrogen, progesterone, and when it looks mature, we can go and extract the egg with a little needle. And so it's not a big surgery. It's about 10 minutes, and you can go home after that. So you don't need a hospital.
So let's say a couple has been trying to conceive for a year. They come to your clinic. So what does one expect on the first clinic visit?
So we try to gather the history of the couple to gain insight into what could be potential sources of problems.
Oh, like history of infertility in the mother's side of the family or father's side.
Right. Or if a woman's menstrual cycle sounds normal, regular, if there's any issues with intercourse, any ability to detect ovulation. There are ovulation predictor kits that women can use at home and know that they're going to ovulate tomorrow. And so if they have been appropriately using that, they have a better chance of being pregnant on their own.
And also they have polycystic ovary or other systemic diseases that make fertility a problem.
So you can gather a lot from the history. So if you have irregular periods, you may not be ovulating. Or if you're not ovulating, then you can't get pregnant. And then if they have history of infections, pelvic infections, surgery in the abdomen, even appendicitis, sometimes can cause adhesions around the tubes and ovaries. And so we will gather those history. And then we do testings to assess what the ovary is like hormonally, hormonal tests. So that's a blood test. We do ultrasound to look at the ovary and the uterus.
This is on the first visit?
No, usually we have to do blood tests at a particular time in the period.
Oh, right.
So we don't do it on the first visit.
So it's another visit.
Or lab order. They can go to a LabCorp or a nearby lab to get the hormone test done. And the ultrasound can be done on that visit, or they can come back. And the other test that we have to do time to a woman's menstrual cycle is a test to see if their fallopian tube is open, because if the tube is not open, then it cannot get pregnant naturally. It makes it very hard.
When that's time to the person's menses or menstrual cycle, then they are coming to your office for a little procedure, a minor procedure. So one would expect 3 visits, typically.
Typically, to complete a workup takes 1 menstrual cycle.
So it depends when you come in for the very first visit, where in the menstrual cycle.
Where they are. We're very much enslaved by what the ovary does.
So usually you could do it in 2, but probably 3. What's normal?
Usually people need to go get blood drawn at one time point in the menstrual cycle, in the very beginning, 2nd or the 3rd day. And then they can come back to do the test to see if their fallopian tube is open and an ultrasound on the same day. So that's 2nd visit. And then the husband or the partner has to do semen analysis. And so
at some other time.
They can come together on any of those days, or they can come separately just to do the testings. So
they expect probably like minimum 28 days of waiting before what you would then tell them the diagnosis or the plan for that particular patient. And then if they decide to have in vitro fertilization, so then what's the time period for that?
Usually it turns out anytime you ovulate, an egg has actually been growing for about 2 months before. So we say the preparation starts about 2 months before. So before we actually do the egg extraction, we encourage women to be very healthy. So we go over even nutrition, lifestyle, suggest acupuncture, vitamins and supplements, because we do think egg quality is very important. And then the month before, the menstrual cycle before, we do what's called priming, or we prepare the ovary in an optimum way.
So you were talking about nutrition and stress levels. So what should they avoid? Wine? Should they avoid beer? Chugging the whiskey? What do you tell them? Cigarettes?
Right. So definitely smoking, any form of smoking can affects the quality of the egg and the sperm. Alcohol, during the stimulation, during the treatment, we would say no. Caffeine can constrict blood flow. So anything that has to do with decreasing blood flow, we think can impact the ovary's way of responding to the fertility treatments, and even for sperm. So we discourage those, even starting about 2-3 months before.
So, you know, cannabis is now legal in California and many states. How does that play in this nutrition and all this other stuff?
There's not a lot of data on cannabis because it only became legalized recently. So we don't have a lot of good scientific data on the effect of cannabis on eggs and sperm. But smoking marijuana, smoking a joint, etc., does increase carbon monoxide in the circulation. And so that has been shown to affect egg quality in sperm.
So the first 2 months, this egg is getting high quality lifestyle changes. And as it's getting high quality lifestyle changes, you then have to examine the female patient again because you have to figure out when they're ready for the implantation, right?
So then we are actually just trying to optimize the ovaries condition with some hormones before we start stimulating the ovary with fertility medications. That starts with a menstrual cycle as well.
So this is all time to when the menstrual cycle is?
Starts.
Oh, so one would expect a few more visits.
At that time, no, usually you don't need to do a visit until the menstrual cycle starts. And then you visit us about 4 or 5 times over about 12 days. Average is about 10 days, but some people have shorter treatment. Some people have longer treatment because every woman's ovary is different.
This is when you're going to stimulate the ovary, when you're visiting over 10, 12 days. And that's usually with Pergonal or?
That is usually with what we call follicle stimulating hormone. So they're recombinant follicle stimulating hormone where the drug companies copy the human gene. And so it's the same as what our own body produces. And then that can be taken as small injections that women have to give themselves every day.
So during this 10, 12-day period, which is key to the menstrual cycle, then you have to figure out if the ovary is okay. So you have another ultrasound?
You do multiple ultrasounds. So the 4 to 5 visits are ultrasound and blood test. And you're seeing how the follicle, which is what an egg is in. We can't see the egg because the egg is 100 micron. So we see a little black bubble that the egg grows in. And as it grows, it should make more and more estrogen. And so we're also measuring the estrogen level.
So you're watching the rise?
Correct.
Oh, so that's why you get the multiple blood tests.
Correct.
So now you can do very small estrogen samples, or you have to get a whole tube?
You can pretty much just do blood. That's not yet. People have tried finger sticks, but
it doesn't work
it's
yet.
Not reliable.
Okay.
And it's such an important information.
So they want reliability. Okay, so then after this period is over and the ovary is stimulated, then what happens?
Then we get ready to extract the eggs. So we call that the egg retrieval. And so that's done with ultrasound guidance. A small needle, it goes into the ovary through the vaginal skin. And there is sedation administered by the anesthesiologist for about 10 to 15 minutes. And then we go into the follicle where there should be an egg. And so hopefully there's multiple follicles and multiple eggs.
Then you extract them. And then we don't do genetic testing yet.
Nope.
So then they are then put in a petri dish.
Well, we fertilize the egg.
Right.
With sperm is collected while the woman is undergoing the egg retrieval. And so both end up in the lab at the same time.
Okay. And so I am sure that during this time period of the 12 days, everything, the couple feels stressed because they already failed conception the natural way. And so this is when you tell them to do, is that when you suggest acupuncture or all the other relaxation techniques?
Yes, we actually suggest acupuncture about 2 months before the whole process because it improves blood flow and energy flow to the ovaries, helps reduce stress. All those can affect how a woman's ovaries could respond and produce or not produce many follicles.
And then, okay, so once you do the follicle extraction procedure, and then what happens? You have to
So
wait.
every egg doesn't fertilize. Every fertilized egg does not become a successful embryo. So unfortunately, that's why we try to get many eggs. About 70% of eggs will fertilize on average. And from that fertilized egg, only about 50% will reach that 6-day-old embryo.
So there's little parts of failure along the way.
Along the way. And then from that very end, if you do genetic testing, people are very surprised that even in young women in their 20s, about 30% of the embryos have abnormal chromosomes. But that makes sense when you know that average women in their 20s miscarry 25% of the time. So it's very close to that 30% rate.
So a lot of those 25-year-old women who are miscarriages, they don't even know because it's part of their menses. Is that true?
Yes.
So they wouldn't know.
They wouldn't know.
Yeah. And then after this is done, past the 6 days and you do genetic testing, and then the couple just waits?
Right. So we cannot put the embryo in until we know the genetics, and that takes about 10 to 14 days. So the embryos are frozen. The cells that were extracted from the placental cells will be analyzed. Its DNA will be extracted, and they will do what's called next generation sequencing and really see how many copies of each chromosome are in those cells.
So during this process, I think that they've already identified spina bifida and all the more common ones, right? What other things do they look for?
So things like Down syndrome, and those are due to chromosome numbers. If you have a family history of genetic conditions, and we know which gene that partner and the patient may carry, we could also screen for those in the embryo and only put in the normal embryos, so you're not passing on anything that might be heritable. So before we actually do IVF, part of the workup involves offering patients genetic testing to see if we can detect any mutations that will put the baby at risk.
So we're now probably 20 days into the process, right? It's about 20 days. And then once you figure out the genetic dangers or risks, and then you then put the
normal
embryo back into
the uterus.
That's another procedure.
That's just a tiny little plastic catheter that slides into the uterus. It's painless. You don't need anesthesia. It's like in 2 minutes. We do a lot of preparation to make sure the uterus is in good state. So that takes also a month and a half to prepare.
So the uterus, you're checking because you're getting hormone levels.
You're
right?
checking hormone levels. You do ultrasound to make sure that the uterine lining has a very nice pattern and thickness. So those are ultrasound and blood tests.
Okay, so now we're at 6 weeks.
From the very beginning?
Right.
Yeah.
We're about 6 weeks.
One menstrual cycle is for egg extraction and creating the embryos. And the embryo is tested for genetics. That genetic test doesn't come back until a woman has already had their next period. So that cycle, we don't do anything. We also let the ovary rest, because it turns out that a woman's ovary that were hyperstimulated, if you put the embryo in that state, it doesn't do very well. So we wait for the ovary to come back to normal, be more physiological. But then we focus on, are there any abnormalities in the uterus? Are there polyps? Are there irregular structures that might interfere with attachment? And if that's normal, then we go, okay, now that we know which embryo is normal, we will make sure your uterus is optimum and then put it in. When normally an embryo comes into the uterus is around the 3rd week of the menstrual cycle. So that's what we do. We wait for the 3rd week of the menstrual cycle.
So this takes like 3 menstrual cycles.
Correct.
So minimum 3 months and the 3rd week of that one. So we're about 4 months. And then when is the patient going to be relieved that everything is okay? When will they know?
After we transfer 9 days later, we do a pregnancy test.
And you're looking for a human
Chorionic HCG hormone level.
Okay.
That's a blood test. You can also do a home test, but we do blood tests.
More specific and more precise.
More precise. And it also tells us how well the placenta is growing now, because that's made by the placenta cells. So there's no blood test that's detecting how the body of the baby is developing, but just the placenta.
So when we check how the placenta is doing, there's still no finger stick, because it's still not reliable.
Yeah.
You have to get a tube of blood.
Yeah.
Okay. Okay, so now this is about first trimester.
This is what we say 4 weeks.
4 weeks.
Because you count from the last menstrual period.
Right, okay.
And then we repeat that blood test to see that it's rising appropriately, because if a pregnancy is growing, the HCG level goes up.
So then you repeat it 1 month later?
No, just 2 days later or 3 days later.
Oh.
And if it's going nicely, then we do an ultrasound 2 weeks later.
Wow. So all this stuff is going to be done outpatient?
Outpatient.
And all infertility centers have all this equipment?
Yes.
And they also have the equipment and the surgery rooms for the anesthesiologist and everything?
Correct. So we have a certified ambulatory surgery center immediately adjacent to the IVF lab, so that any eggs extracted can be immediately given to the laboratory through a little pass-through window.
That's really efficient. That's good. Now, on to this other topic of preserving fertility. How is that? The patient comes in and says, I'm too busy to have my babies. I have not found Prince Charming, and I want to save my eggs.
Right.
Is that usually what happens? Are they usually 25, 30, 40? What age are they? What's the average age?
Oh, there's actually studies, because if you did it too young, you still have lots of years to find somebody and have opportunity to get pregnant naturally. So we don't necessarily recommend it if they're too young, unless they have some disease that merits that they're at risk for losing their ovary faster, or family history of very early menopause. So if they have concerns, it's okay to do it early. But majority of women, the best time to do it is somewhere around 30 to 35.
So then they come to CCRM and they see you, and so then you again take the history and you get blood tests to see their hormone levels.
Right. We are assessing what their ovary is like how much ovary a woman has. They're born with fixed amount, and you lose them over time. And some women are born with very big ovary, and some women are born with small ovary, and you have no idea. You could be very healthy, organic, exercise, and have small ovary, or you could be unhealthy and have large ovaries. So you have no way of knowing.
So you mean the size of the ovary matters? Oh, I didn't know that. But I thought that women were born with a certain number of eggs, but you can't count them all. So
you can't count them.
So therefore, you just measured by size.
The whole size of the ovary and the hormonal measurements.
Oh,
So
that's
there are markers that gives us some idea. Are you somebody that have lots of eggs still? Or no, you don't have many eggs now, so then you want to do this sooner than later. So we start with fertility assessment first. And now that we know a lot about this, just coming in to a fertility specialist to consult that could be like your general health checkup, like a pap smear. Why not in your 30s do that, so you know, oh, I might think about freezing eggs earlier than later if there's a concern.
Do they have like data about women who smoke and versus those who don't smoke, about the size of their ovaries?
They have data that women smoke go into menopause younger.
So that the actual ovary size becomes smaller?
Smaller faster.
That's interesting.
They're losing eggs faster.
And the same thing if they have recreational drug activity or high alcoholism and all this, does that play a role?
Well, there's no specific data on that, but there's probably association, because people that tend to do other drugs are also frequently smoking or have other substances in the state that could affect the egg
And
aging.
then what if people have diabetes or hypertension early, or collagen vascular disease that also, and also thyroid affects?
Thyroid or autoimmune disease. So autoimmunity can affect thyroids and glands like adrenal and maybe even the ovary. So those women have higher risk of developing what we call lower ovarian reserve, like smaller and smaller ovaries faster.
We're coming towards the end of our show. This has been totally fascinating. So please call Dr. Salli Tazuke with all your questions about fertility preservation as well as IVF. And for our take-home, the take-home message for our home audience is that better to see an infertility specialist early by 30 to 35 rather than waiting till age 40.
Correct.
To get what's new and to see what's available. And thank you very much for joining us.